Perfect. All right. Welcome, everyone, to the March 3rd Friday Addiction Toxicology Case Conference. This is Tim Wiegand from U of R. We've got Gloria Bashevitz, addiction psychiatrist, and Ken Connor, professor of psychiatry and emergency medicine, with me, along with our residents and fellows. And I see we've got about 17 different sites, so this should be some good discussion. I'm going to jump right into the first case. We have on our third Friday. It's a 32-year-old male who is post-incarceration for 6 weeks. He has been out and living in a shelter. He has a history of polysubstance dependence, reporting cocaine, alcohol. The alcohol's been remote. He hasn't drank for several years, even prior to his incarceration. And opioids. This is just by self-report. He was incarcerated for about 2 years, and after getting out, he reports a craving for opioids since getting out. He was using oxycodone and Percocets prior to his incarceration, along with the other drugs. He said he had some experience with street Suboxone, but has never been on a prescription for buprenorphine. His admission urine is completely negative for any substances. This is his admission urine. It doesn't show all of the analytes. There was also fentanyl and buprenorphine is at the bottom. They're all negative. So he had a negative screen. He was enrolling in the outpatient treatment program because of the history of substance use disorder and post-incarceration as part of his probation requirement. He denies craving for alcohol or the cocaine. He's healthy. He lives in an area shelter waiting on housing options, and he smokes 1 pack of cigarettes a day. He's been smoking since getting out. So what are your options for treatment in this individual who's not returned to any use but in a treatment program and reports a craving for opioids? Let me see if anybody on the webinar, just raise your hand and we'll unmute. How about, I see guest Myra from one of the area treatment programs has joined us today. Myra, can you unmute? What do you think for this gentleman?
Can you hear me?
Yes, good.
Hello? Yep. I think for this gentleman, I would talk to him about possible Vivitrol for him because he hasn't returned into any opiate use at the current moment, so there's no concerns for precipitated withdrawal, and it can potentially help also with his alcohol history. I would primarily talk to him about that one first.
Good. What about what if there was resistance put up at that first visit? He was very focused on getting buprenorphine.
That's a tricky one. I think that I don't know what I would do. Maybe try a week of oral naltrexone and see how he did with that, or if he was still resistant to that, then do a low-dose buprenorphine. Okay,
very good. Dr. Bashevitz, do you have thoughts?
I think it would be interesting to know a little bit more about what sort of shelter he's in, because there are some shelters that are very well supervised and others that are not. So one of the concerns would be, will his buprenorphine get stolen or passed around in some way? So you might actually consider even subblockade, the buprenorphine injectable, if there's appropriate insurance and so forth.
Those are good thoughts. He was in one of the less monitored shelters in the area. There was no medication storage. It was a lot of drug use, and that's what he also reported, is seeing people that are getting high in the shelter, and that was triggering him. Now, for the subblockade, from my understanding, they have to be stable on buprenorphine for 7 days at a certain dose. So without having a history or having recent opioid use, it would be a little work to get them onto the subblockade. That may be a good option if that's eventually the path. Would the shelter status in and of itself be the main driving factor? Would you offer him buprenorphine or?
Yeah, I'd offer him buprenorphine. I don't see an objection to that. I mean, there are plenty of people who can manage with a shelter.
Okay, very good. JJ, I see Dr. Asimas. Do you have a comment or thoughts about this case?
Yeah, I think it is good to try to be flexible about people's psychosocial situations when it comes to offering treatment. I know that we have lots of reasons to want more structure if we can have it, but some of the data that we have about people presenting relatively acutely with addictive needs and either asking for buprenorphine or we think it's reasonable, we've got some suggestions that starting them on it is so stabilizing because it's not just about addiction, it's also about their affective experience of using or not using or having been dependent on substances. So I think I might meet him where he is because it's reasonably safe to do it. And then we could talk about trying to integrate the alcohol treatment going forward after we've made step one with him closer to what is fitting with his request. Because I don't think what he wants is unreasonable, even if, like, I agree with the first comment that it would be nice to see him on naltrexone because of the comorbid conditions. But I think starting where he is probably a reasonable thing to do, too.
Good. Good comments. Thank you. Does anybody else want to comment? Ingrid, do you have some thoughts?
Oh, can you hear me?
Yes, good.
Hello, can you hear me? Yes, can you hear me?
You're on.
Yeah. I guess I wasn't sure if I could unmute myself here, but I guess I'm wondering from the rest of the group, what is the evidence that Suboxone will specifically deal with cravings? My understanding was that in terms of using Suboxone, it's great for the withdrawal. If you're in a significant withdrawal, then, you're able to deal with some of those cravings. But generally, cravings ends up being something that you need to look at counseling and other relapse prevention type of therapy for. And I don't know that I've seen any literature on Suboxone and cravings specifically, but maybe I've missed it.
That's an interesting thought. I'm thinking as you commented, and my initial reaction is of course it helps the cravings because I hear this directly from the patients. The cravings go down and all of the other things associated with cravings decrease too. But I'm trying to think of your specific question about research. Looking at craving score going down, I would have to look at the research. My thoughts would be there, but Gloria, do you know?
I don't know either. And I know that there's a lot more research now on cravings versus urges versus just simple resolution of withdrawal symptoms, which of course would then help cravings. So I think a lot of this stuff needs to be teased out. But like Tim is saying, the patients are almost unanimous in saying that Suboxone does relieve their craving.
Right, but this guy has been opiate free for 2 years, right? So I understand that he now has cravings again, but he is not currently using opiates unless he's not telling the truth.
Right, that's what his report is. But he was post-incarceration and now in a very vulnerable environment, and that's there's certainly debate over what to do. With this case, he's very high risk for overdose if he returns to use. Most of the heroin in our area has fentanyl in it, and he's doesn't have a lot of other risk factors for overdose in terms of benzodiazepine use. He's not drinking, return to drinking. He's otherwise pretty healthy, but
so then, in terms of what, in terms of what you're saying, my sense would be that he could be given buprenorphine because that's what he wants, and it's being used as a harm reduction so that if he does succumb, that he ends up and he wants to use, that then he doesn't die because of the fentanyl that's out there. Rather than we're treating his cravings, we're treating him for harm reduction. That makes sense to me.
Thank you. Henry, do you have a comment or question?
Yeah, I guess I just had a question. I'm not aware of any specific evidence that any specific counseling actually helps with with cravings. I guess I certainly have patients who are involved in counseling, and I have patients who are on Suboxone, and they all report varying degrees of cravings that, like you said, do anecdotally seem to improve with Suboxone. I guess over time. The one thing that I can think of as far as research regarding Suboxone, and I forget the exact paper, but I know in the PCSS slides there's a graph that shows that Suboxone doses over 1 milligram help with cravings more than just 1 milligram. So there's some data at least that these doses that are more within our therapeutic range actually do assist with cravings.
Yeah, that's it. I can actually picture that slide. I gave that course, part of the course this weekend with a couple of other individuals, but I don't recall if it was specifically the craving or use, but it seems like that was essentially the gist of it. But yes, those are great comments. We're going to jump ahead. So, I think a couple of different perspectives. He was very focused on starting Suboxone specifically, but he doesn't have chronic pain. It's been 2 years and 6 weeks. I pointed out that he hadn't returned to use, and that I wanted to try naltrexone because, in my experience, that also can help cravings through blocking endogenous opioids, cue-induced cravings, and it would be overdose prevention as well if he returned to use. And he had, even though he hadn't returned to drinking, he had a substantial alcohol history. That wasn't my primary focus with this, but it may be useful. So the plan was to start tablets and then administer the IM naltrexone, the Vivitrol, the following week, kind of holding his hand through this and bringing him back. He was a little bit crestfallen, but agreed to try this. I think if he had adamantly refused to do this, I would have started a low-dose buprenorphine, that day and brought him back, maybe a 2 milligram. And he follows up on Monday. You see it on a Friday, and he states he's not taking the naltrexone. He says, my muscles ached. I had no appetite all Friday or Saturday. That stuff is terrible, and you don't want to try it again. He was very adamant and emotional about the naltrexone. So questions, comments? He says he's feeling a lot better now, but there is no chance he's going back on the naltrexone. Dr. Bishevitz, do you have any thoughts about this one?
Well, the muscles ache thing symptom, I haven't heard too much. Usually it's nausea and vomiting that bothers people from naltrexone. But, if he says no, it's no. And, you could go into an academic discussion with him of IM naltrexone supposedly avoiding the first pass effect and therefore less side effects. But I have found that most human beings don't like that argument because they've already felt the side effects from the PO naltrexone. So it doesn't make a lot of sense to them to take an IM that's going to last for a month and with the hope that side effects will be less. So I think you're left with just talking more with him about possible buprenorphine.
Yeah, and I think what perplexed me was, the degree of his side effects from the naltrexone. I've had some individuals that get headaches and, some mild nausea, but, it's real mild. He really was pretty adamant they were significant, more than I've seen patients just with general naltrexone. JJ, you have your hand up do you have a comment again?
Yeah, Tim, with this part of the story, it feels like perhaps we've precipitated a bit of withdrawal. It has me curious as to wonder whether or not he may have found some of his own buprenorphine because he didn't get what he wanted and maybe mixed it together with a little bit of naltrexone, and that's why he's experiencing this. Either that or he had some opioid in his system when he started his naltrexone again. He had a bit of a reuse or a relapse or something like that because as you were talking about, the side effects from starting naltrexone when you're opioid abstinent, you wouldn't expect to be this significant from a systemic standpoint. But those muscle aches, especially if they're in large muscle groups and are kind of characteristic of opioid withdrawal. This may be precipitated withdrawal, and it's because he's either mixed it together with another full agonist from his use, or even maybe he found some Suboxone from somebody else, and that's why he's having the trouble.
Yeah, those are good thoughts. You've got a couple people nodding, I think, around the circle here. Certainly, to have that right after the naltrexone suggests more than just the medication standard adverse effects in an opioid-naive individual. Although, so there's two camps. Either the precipitated withdrawal was what I was thinking, or this gentleman is really interested in the Suboxone and is just, planned on, I'm not going to take it, I'm going to have side effects from the beginning, and no matter what, it's just not going to work for me. And I've had some of them, very focused on not getting anything but the buprenorphine, and sometimes it's because they have ulterior motives. Other times it's because they're just very focused on that's what they want, it's worked, or, it's a known commodity. So,
sure.
This is
effect.
Then, go ahead.
Right? This would be a nocebo effect. He expected to have bad experiences.
Yeah.
That's good, yes.
Yeah.
So I've included a protocol. This is a New York Department of Health protocol. It's in draft form. I took it out of a longer document. This is the initiation of naltrexone. Now this is for initiation related to alcohol use. The only difference between this and opioid use would be the duration of time in between short-acting or long-acting opioids. You'd wait longer for somebody that has an opioid use disorder. This is in process because I thought that the 2 days from short-acting opioids and 3 days for longer-acting opioids, even if you're not opioid dependent, should be longer. I was concerned that there would be some symptoms from this, but there's a lot of confusion over how to start naltrexone in general, and there's a very different world of opioids than just simply short-acting heroin. And when we're starting naltrexone, we have buprenorphine, you have fentanyl patches, you have methadone, and there's a lot of different opioids potentially out there, and each would kind of have a subtle different duration of holding the opioids and way to get a person on. Most of the patients that I am able to get naltrexone initiated in, it's actually through a rapid induction and up titration from 1 milligram to 3 to 6 to 12 to 25, taken with clonidine and diazepam in a controlled setting, and then giving them the Vivitrol shot because it's hard for patients with opioid use disorder to wait a long enough time in between the last opioid to getting the Vivitrol shot. There's a lot of dysphoria, and even if you do a taper with buprenorphine, it's a very difficult, challenging time. The common adverse effects with naltrexone: headache, nausea, symptoms associated with precipitated withdrawal if you're starting the naltrexone after an opioid, muscle spasm, GI upset. This is the gentleman's urine drug screen the day of naltrexone initiation. So, JJ, you were right. He had taken some buprenorphine, despite going through this very carefully in terms of you're sure you haven't had any use. Naltrexone's a blocker. If you have an opioid in your system, it's going to knock the opioid out. You're going to have precipitated withdrawal. He was very adamant that he hadn't returned to any use, and his initial screen for the treatment program was completely negative. Now he has, at least on the day of the presentation, he had a small amount of buprenorphine metabolites. And then this is not very much. This would have been taken right before he went to the pharmacy to get his naltrexone, but it's enough to have some reaction with the antagonist. Any thoughts or comments? Would you, Gloria, expect the symptoms after?
Well, the symptoms seem a little bit extreme. In a way. I would suspect maybe he had used more. I don't know. But my main thought is a sort of a logic exercise that the answer that you're looking for now is buprenorphine, because he is using buprenorphine already. And so, if he is, fine, you give him buprenorphine. If he isn't, if he's got an unusual naltrexone effect, then still the answer is buprenorphine.
Right. I think as I pulled this open, I was kind of surprised. I said, if you had told me you had taken buprenorphine before the visit, that would have directed me in another way, and we could have avoided some of your symptoms. I thought it was a little dramatic for the amount of buprenorphine in the system, but certainly sometimes individuals are sensitive, and when you're not expecting anything, you have some patient experiences some of the mild withdrawal, they can be interpreted as certainly not good. So I think he had a little bit of mild, very mild withdrawal when he started it, and whether he could have taken another dose of buprenorphine right before picking up the naltrexone, well, that would have not been a good idea. I would have expected much more severe symptoms, but so he reported use of heroin after I pulled up his screen on Sunday. Now, he's being seen on Monday, and he'd stopped the naltrexone after the single dose on Friday, was miserable Saturday, and used heroin on Sunday. And in fact, the dipstick that day, did a urine dipstick, was positive for fentanyl only, no buprenorphine. And he was sent to the pharmacy to pick up a dose of the buprenorphine films, the 4 milligrams, and had an observed dose with a half of a 4, and instructed to take 1 4 a day with follow-up later that week. Tobacco cessation was offered. He declined. He did miss the follow-up appointment a week later, but he was started on buprenorphine with the plan to see how he settles out with regards to dosing. Any thoughts or comments on this case? Katie Hurlbut, you have a comment or question?
I'm sorry, I had to step out for a second, so I haven't heard the last 5 minutes of this. I'm sorry.
Sure, no problem. Henry, other thoughts?
No, nothing too much to add on that. Yeah, you know, my only thing, you know, this is more of an outpatient case, but it's definitely been my experience on my inpatient service when someone, you know, is ready for Suboxone and, you know, or they want it when they're in the inpatient setting. I just have had better luck retaining them when I start them on Suboxone than if we decide to pursue the naltrexone route. So I generally have a low threshold to even start people who have been detoxed, you know, back on the Suboxone. That's my personal practice.
Yeah, I think that's been more and more my experience, and unless I'm really skeptical that there is an opioid use disorder, I would, I still think, you know, I would offer a choice potentially with naltrexone, and in some individuals maybe agree, like in this case, that we would try it. But I think my take home is next time do a dipstick if we're planning on doing this, and if there's any concern, either a dip and a naloxone challenge or a small dose of naltrexone before a bigger dose. Let's jump in. I have inserted a second case because it's very much in line with the subject matter of this case, and I wanted to get some thoughts on this. A 36-year-old male was admitted to an area detox to come off Suboxone. He had not been doing well on buprenorphine. Every time he gets more than a couple of doses, it's a trigger, and he goes off on a cocaine and heroin binge, and then he's out, and then he has to go back into the treatment or detox. That he says, I'm done with the subs. We're not going to do this anymore. I want to get on to Vivitrol. The protocol for opioid withdrawal is clonidine, 0.1 milligrams, 1 to 2 every 6 hours as needed, and hydroxyzine, 50 milligrams, 1 to 2 every 6 hours as needed. And the buprenorphine induction, because he came in after using 15 to 20 bags of heroin a day, is day 1, a 2 milligram dose, and then an hour later, 3 2 milligram doses. So the induction is 2, then 6 or 8 milligrams. And day 2, he's given a 4 milligram dose of buprenorphine, and he's out of withdrawal and doing okay. And the plan to start naltrexone, not the following evening, but the night after. This is done quicker because he is only a limited amount of time he can stay in the detox before he has to get inpatient, and he's got a kind of a plan. The induction protocol, this rapid induction, is a 1 milligram naltrexone dose at night, followed by 3 the next night, followed by 6, followed by 12.5, followed by 25, and then the following morning, a 50 milligram dose, and then the Vivitrol shot is given on the day of discharge. The naltrexone is given with a 0.2 milligram of clonidine and a 10 milligram dose of diazepam, and basically the patient takes it, goes to sleep, sleeps through these mild precipitated withdrawal, and essentially has, instead of waiting 10 days to get the shot, this is compacted and they're kind of pushed through withdrawal. Day usually 2 and 3 are a little bit rough, but after that they're doing pretty well, and sometimes this can be expedited. But instead of a 1 milligram dose, the nurse gives the patient the regular 50 milligram tablet for day 6, about 60 hours after the last 4 milligrams of buprenorphine, and he'd been using about 15 to 20 bigs of heroin. And 20 minutes after the dose, patient's doing okay. The nurse that did this notifies the covering physician of the mistake. So I'm wondering, no symptoms, a 50 milligram dose of naltrexone has been given about 60 hours after buprenorphine, and within the few days prior to that, a lot of heroin and more buprenorphine. Any thoughts? Will this gentleman have precipitated withdrawal? Anything to do ahead of time? How would you treat, what would you anticipate and how would you treat? Gloria, you want to comment? Any thoughts? If you heard about this from the clinic, what would you advise?
I'd observe the patient first to see if he got some kind of precipitated withdrawal.
Sure.
Because it's been 60 hours already, and maybe he can tolerate the 50 milligrams at this point. If anybody has comments or questions, just raise your hand. Otherwise, I'll continue to call on individuals. How about Lynn? Do you have any comments or questions? Or anyone at the Syracuse Tox Fellowship want to comment?
Tim, it's Gina. Just a question. This was an oral dose, right? I think I missed that.
Yes, this was an oral dose. This was 50 milligrams of the naltrexone tablet, 60 hours after 4 milligrams of buprenorphine, the day before that 8 milligrams, and the day before that a lot of heroin. So this is, but it's been 60 hours.
Our big question, and I don't know this off the top of my head, is the peak effect of naltrexone orally. I thought it was more like an hour, but I'm not 100% sure on that. I don't know if you know that off the top of your head.
It's an hour. One of our clinical pharmacists here has confirmed it's an hour. Yeah, I think that's a good point. 20 minutes is too soon for this, but it's not going to be an all or none immediate effect. It'll start to build, I anticipate. When I've seen patients take naltrexone too soon, and I've seen it a few times, it starts and symptoms kind of build and build and build, and then they, within 24 hours tend to dissipate. But I'm wondering, is there anything you could do to head off? The nurse asked over the phone, what if I make him vomit? Do you think that would be? So he said, no vomiting, just watch and let's wait for the symptoms. But I did have them give a little, no charcoal on site. I think that would have been interesting. There's no charcoal on site for where he was being treated. And I thought with 60 hours, maybe there's going to be enough time for him to have mild symptoms. There's a lot of variability in doing a rapid naltrexone protocol, and some individuals go through absolutely fine, very minimal, and others really struggle. It's kind of like you would expect if there's more opioid in there to begin with, and in particular more long-acting opioid like buprenorphine or methadone, it's going to be more challenging to get through the naltrexone. But I had him give another 0.2 of clonidine and 5 milligrams of Valium, thinking we're just going to kind of and some Zofran to head this off with symptoms, and he can maybe sleep through it, kind of like the protocol calls for with the lower doses. About 3 hours after he was given the naltrexone, he starts to have restless legs, a lot of sweating, cramping, and nausea, and kind of like I described, it builds. But the clonidine helps substantially, and he doesn't vomit. And overnight, he takes some clonidine and another dose or two of diazepam and is able to kind of get through the night. In the morning, he's still restless and sweating, but the bulk of the symptoms have dissipated. And later the following evening, he doesn't have precipitated withdrawal symptoms, and he agrees to continue on the induction. We jump ahead to the 12.5 milligram dose with clonidine and Valium. He tolerates that, and he is completing the induction, does fine with the induction. But the clonidine and the diazepam really help kind of dampen down symptoms, I think, in advanced pretreatment of his precipitated withdrawal. Any comments or thoughts? Has anybody treated a naltrexone precipitated withdrawal? Rachel, you have your hand up. Just barely. Yes, go ahead.
I've treated actually a couple pretty severe ones, but my question was, did you think about using buprenorphine? Because I've seen a couple case reports of buprenorphine used to treat precipitated withdrawal from naltrexone. Just because the binding affinity is so avid?
Yeah, I think, that's a good thought. I did consider it, but his plan was to not. It was an accident, but it wasn't like he took the wrong pill on the street and has no intention of getting on naltrexone. If he didn't have any intention of getting on naltrexone, I think that would have been a really good plan. And if it had gotten more severe, wasn't tolerating the clonidine and Valium, was getting too sleepy with still precipitated withdrawal, I think that's a great idea. I think that's a great. I've not done that for naltrexone precipitated withdrawal, but I've done that when buprenorphine is precipitated withdrawal, and not immediately after naloxone, but I think when the right case presents and somebody gets a big slug of naloxone at the short-acting opioid, sneaking in buprenorphine right after would be very reasonable. So that's a good thought.
Yeah, I had a patient who went into a hypertensive crisis that we had to treat with not only IV clonidine, but IV nicardipine and a lot of benzos to try to get her through it. But it really seemed to peak at 24 hours.
What was that after? That was 50 milligrams of naltrexone after?
That was after
what
Vivitrol,
kind of?
So the IM naltrexone.
Ah, I see.
Tim, I don't know.
Go ahead. Yep.
I want to bring something up. This keeps coming up as to whether or not we can start buprenorphine in patients who have just received naloxone, either in the setting of overdose or in this setting, and they're in functionally acute precipitated withdrawal, whether or not it's safe to start buprenorphine at that time. And I don't know the answer to it. I've heard some people say that they've done it, but I've never seen anything in a peer-reviewed source that says that it's safe to do. I think I could see why there might be some biofeasibility as to why it might work, but I also, I think where it's a little bit, I'm hearing two stories, is that we're also very careful about starting buprenorphine in patients who aren't even in acute withdrawal yet. So whether or not it's going to make them better or worse, I feel like I don't know the answer. So I'd love to hear somebody with more experience that they've actually done this, where they've treated acute withdrawal with buprenorphine, and whether or not there's anything published on the case report or case series or safety data otherwise.
Yeah, those are good comments. And I've heard people discuss this as well, about starting it right after acute overdose, but I've not seen that borne out in the literature. And I think it's feasible if you do it right, but it also has potential to cause a lot of problems with the timing. You need to get it in, and low doses you could go low and then rapidly titrate up, but you'd have to know what type of opioids did they use. Were they completely reversed? Was it just a little bit? There's also a lot of methadone. There's a lot of variables that this would be no one size fits all. Does anybody have any experience with that online?
I don't have personal experience, but I've seen a case report that was an abstract, and then I saw a case series of it it was almost a buprenorphine induction that they were doing in a clinic. I don't remember the exact reference off the top of my head, but I can send it to you.
Well, that's different though, right? If you precipitate acute withdrawal with buprenorphine and then you give more buprenorphine to treat that acute withdrawal, that I think I have seen and I've been told. I don't know that I've ever done it myself. I remember Ross telling me about a case where I think he might have done it, but I think that's different than acute precipitated withdrawal from an antagonist like naloxone or naltrexone, you know?
Yeah. I've done that in clinic many times when an individual takes it, they feel worse. And then we tell them to take some more. And they'll feel better. They'll start to feel better.
I've done that many times as well, yeah.
They look at you like you've grown a second head.
Right, right.
Yeah.
But generally it works.
Yeah, that's good. Do you have any thoughts about this case?
I don't think so, no.
Buprenorphine after buprenorphine is going to be a bit different, I think, than the naloxone. The timing would be the key with the naloxone. So, but this gentleman, it was impressed that he was still motivated to try the naltrexone. There was a lot of hand-holding, and he had supportive medications and did all right. In my experience, enough clonidine for precipitated withdrawal is one of the most effective things that, adjunctive treatments if the situation isn't right to use buprenorphine. All right, let's go on to the next case here. So switching gears a little bit, a 27-year-old male receives his first sub-Q buprenorphine injection. This is the monthly Sublocade. He'd been doing well on buprenorphine, stabilized, and wanted to try a Sublocade. He returns a week later with redness and some mild tenderness and is wondering if the site is normal looking. This is a picture of his site about 7 days in, and he doesn't have a fever, but it is red. And looking at some of these sites, it's much redder and a little bit warm, and it hurts. It's mild tenderness. So we've had a couple of these individuals that have presented to the emergency department that I've gotten calls since Sublocade has started, been available, and otherwise patients ask. And I'm wondering, does anybody have any experience with this, and what would your thoughts be? Maybe Nick, what do you think? Redness and...
Boy, that's tough. I don't know if that's a cellulitis, if that's a local reaction from the injection, or I suppose you also have to entertain the possibility of tampering, a patient tampering with the site for some reason. If I had to guess, if there was no systemic signs or symptoms of illness, well, actually, I was about to say that it was just local reaction, but it almost looks like somebody's outlined an area there, and the erythema seems to extend beyond the site of the outline. So I'll be honest with you, if I were seeing this patient in the emergency room late at night, I'd have a pretty low threshold of starting a gentle antibiotic and having close follow-up to make sure that's not a cellulitis developing.
Good. Yeah, I think that was my reaction as well, and kind of hearing this and having this photo. Myra, do you have any other thoughts since this was coming, or comments since this was coming kind of from your direction?
Yes, so the area that was marked actually was marked the day of the injection to mark the area where we used topical anesthetic to help with the injection itself. So that circle around is not an area that was marked to see if the redness had progressed. It was something that was there. The patient, this was a week later. I don't know why the patient didn't clean that area by now, but that mark wasn't, it wasn't marked to trace the redness, no.
And he did not have a fever or, other than feeling some tenderness,
he had no itching. He didn't have any itching. He had some localized tenderness to the area. The area was a little bit warm to touch. However, his whole body was warm. It wasn't more warm than the rest of his body. He didn't have any fever, no chills, no nausea, nor vomiting. Yeah, we can palpate the lump from the medication itself. There was no drainage.
I've had a couple of patients that I've heard about coming into the emergency department with, some pain and redness, and, one individual had an ultrasound, and, there's a lot of confusion over what, first of all, what it's supposed to look like. Some individuals haven't understood that this is, supposed to be a kind of a depot of a medication under there, and trying to differentiate, an abscess local reaction from cellulitis, I think, just on looking at the photo is hard. So,
what type of topical anesthetic was put on there?
Lidocaine.
Like a EMLA cream or?
Like an EMLA cream. I think like an EMLA cream. Was it specifically EMLA cream? It's a topical.
Because I suppose allergic reaction to that is also within the realm of possibility. Probably take a history to see if they have any problems with amide anesthetics in the past.
Okay, well.
Can you hear me?
Yes.
Oh, okay. The patient had a allergic reaction to sulfas and penicillin, but not a history of, anesthetic allergies.
So we talked about antibiotics in this patient, but decided no fever, not really warm other than, consistent with body temperature. It had the demarcation, but it was done on the day of the shot. Apparently, so no antibiotics were started. The patient had some gauze put over it to kind of prevent rubbing on his pants, and the redness went away shortly after that, and as did kind of the feeling of irritation. So he was having kind of a reaction from rubbing against his pants, and we've seen this with the naltrexone in the past when people really, get it on the wrong area and they, sitting on it repeatedly. The sublocade shot rotates around the abdomen in each quadrant. So counseling into patients that, and looking for an area where it's not going to be right under their belts or pants potentially, because there'll be a little bit of a nodule there from the depot of the drug, from the resin, and that can cause a lot of irritation if it's rubbing. Otherwise, this patient really likes the shot, and apparently is doing pretty well. Has anybody given or using this depot? I think there's a early clinical trial on the East Coast looking at using it from the emergency departments, not the sublocade specifically, but a different formulation, different company. So stabilizing on buprenorphine and then rapidly giving the subcutaneous shot, which I don't recall if it's a 1 week formulation or a 1 month that they're using from the ED potentially, but that would be a very interesting way to use it.
Tim, can you go back to that picture?
Sure.
So you think that's from something rubbing on? Yeah, I mean, that's pretty high up away from his belt line there. Even if you pulled down his belt line a little bit, that looks more like a local reaction to me. It's well demarcated around the site. I mean, it's not really in a band like where you know what I mean?
Right. Myra, maybe you want to comment?
I think that it was probably an injection site reaction from probably just the injection, and but it didn't seem to, after so I saw him this week. It was normal skin. He said that he was really sensitive to the shirt rubbing, and when he came in, he had like 4 layers on. So I don't know, if he had, a book bag or something that, he was carrying or what he was doing to make the area rub. But it seemed like, putting a gauze over it and advising him to, not touch the area seemed to work.
Yeah, a lot of patients will poke at it because they've got this little nodule and they just perpetually are pushing, poking. You got to remind them, stop doing that. I think Nick, your comment on, maybe he's manipulating it. It would be, I'm sure that there's some patients, I don't know, you can't really, because the resin hardens, I don't think they could extract it unless they were really, really motivated. But they could sit in a whirlpool, put heat packs on it, I suppose, to try and get extra buprenorphine out. That would be it would be interesting. I have no experience on if that really dramatically affects the absorption, but it does for other topical or patch formulations.
Anytime you have a clearly angry area of skin like that, it's going to be sensitive to touch from a shirt or a belt buckle, but I don't know that, with how well demarcated that looks, it really looks to be right around the site of the injection. I would say that more likely the chicken came before the egg here, and he first had a local reaction, and then that was sensitive to the rubbing, and you know what I mean? Not the other way around.
Yep, nope, that's a very good point. Very good point. So we're going to jump into the last case. This is, again, changing a little bit speeds. This is a gentleman who is injecting methamphetamine and IV Suboxone. He's injecting 2 to 3 strips of the 8/2 formulation a day. He is 36 and describes having done this for quite a long time. He's with a cohort of users that this is apparently very common with the stimulants. There's less heroin in the part of the state that, or he has at least less access to heroin, but he injects the buprenorphine with the methamphetamine or cocaine. His urine screen coming in is positive for methamphetamine, cocaine, and buprenorphine. And initially, the intake counselor and he discuss getting on naltrexone, tapering off buprenorphine, the detox from buprenorphine. But a couple of days in, he's requesting that he wants to actually be put on buprenorphine maintenance. Instead of injecting it, he will take it appropriately, sublingually or buccally. So what are your thoughts and options in this patient? If he's coming into an outpatient program or whatever type of treatment program, when we've had patients similar to this coming into the hospital with infections from injecting buprenorphine that want to leave the hospital on buprenorphine maintenance. So what are your thoughts and reactions?
Well, my first thought about this guy would be, would inpatient be more appropriate? I would prefer to observe him in an inpatient facility to see if he would be at all appropriate, while taking the buccal or sublingual buprenorphine. Now, and the other thought, of course, would be, he's a candidate for methadone maintenance. Now, of course, though methadone can be given 6 or 7 days per week observed out of the methadone dispensing window, at some point he will probably get take-homes, and that's an even more dangerous situation because he can certainly inject the methadone or do something else with it, and that would be more dangerous than injecting buprenorphine theoretically. So it's kind of a catch-22 all over. And that's one reason I say inpatient.
I think that your thoughts about inpatient referral are excellent, and actually that's what did happen. But one question I have is, they're given a methadone syrup when they take them? Are they given tablets?
Syrup.
Have you had individuals inject the methadone syrup, or?
Yeah. At times, most of them don't admit it, of course, but people try anything, of course.
Interesting. Is any other comments or thoughts on this case? Has anyone run into this in the hospital setting? Henry, have you run into this in your inpatient consult service?
We really haven't seen a whole lot of patients who inject, certainly not Suboxone. I've had a couple who inject the Subutex, but for whatever reason, I'm not seeing too much of it. But I'd certainly be considering subblockade in this patient.
I think that's a great thought. Nick, you have a couple of cases that this has happened. Do you have any comments or thoughts?
I wonder, we don't have right now a good way to get people on to naltrexone. It's not easy to do. And I just wonder if these are the patients that need to be on it the most. It seems like some of the data that's come out has suggested that once you get a patient onto naltrexone, they seem to do as well as patients on buprenorphine. So, you know, but the challenge is getting them on it. And so I wonder, it feels like to me that maybe that would be the way I would try to go. I guess if they were admitted or in an inpatient program, it would probably be easier to do than from the hospital. If they were in the hospital for a long time, then maybe we could do a 10-day washout and start them on oral, and then link with an outpatient provider who can get the IM naltrexone ready for their first visit. But I feel like that's actually really challenging to do. There's a lot of moving parts and a lot of phone calls that need to be made. So I don't know.
Yeah, those are good thoughts. I think this gentleman really didn't have other opioid history other than buprenorphine. So that was the primary opioid he was abusing.
Wow.
He at one time had gotten some short prescriptions from a provider in the area, but he had gone to get them with the intent of using them with methamphetamine, not to treat really his, an opioid use disorder, although he does have an opioid use disorder. It's an interesting formulation. So there's a lot of misunderstanding about whether or not people can inject the mono product only and not the dual product. The buprenorphine has a fairly higher affinity for the mu receptor. Individuals that do this describe when they use big doses of the dual product that the naloxone is very dysphoric. They certainly have to be they can't be using another opioid at the same time. This is individuals only using buprenorphine. And most individuals that do this will inject very small amounts when they're doing it, not the bigger, like a full strip or half of a strip of an 8. So it was odd, I thought, that he described injecting 2 to 3 of the 8 milligram strips a day, and whether that was just, self-report to get more detox meds or what. But so I was very uneasy in having this gentleman be put on buprenorphine maintenance. I've had a couple of individuals ultimately die from complicated, serious opioid-related infections from injecting. One individual that had other opioid use and would kind of drift back into injecting the buprenorphine films. He really struggled with just injection in general, I think. Did well when he was in a controlled setting, a halfway house, monitored setting. Someone watched him taking every single dose, but at some point that stops, and he gradually gets more freedom, and he each time would drift into returning to inject, and would be detected when he would get a fever and come in with a serious infection. He ultimately died from complications from endocarditis from injecting the buprenorphine naloxone. So, this case, I think I would stick to my guns, and if he was going to a halfway house, potentially monitored setting, inpatient halfway house, I would consider observed dosing, and then the Sublocade, I think, was a great thought. But outside from that, I don't think that would be reasonable to go on to buprenorphine maintenance. Does anybody have comments or thoughts?
Tim, I recently had a patient that I saw in the emergency department who was on buprenorphine, and he told me that his buprenorphine provider was fully aware of him injecting his prescribed buprenorphine, and that his provider was taking a harm reductionist approach by making sure that he had clean needles and was using a clean procedure to inject his buprenorphine. And, my gut is, wow, that sounds like a terrible idea, but I think that I feel like this actually isn't the first case where I've run into. Some providers are doing that, and I wonder about the medical legal risk of taking that harm reduction approach.
I think that's an interesting comment, and we had at the last year's ACM conference presented a workshop of complicated buprenorphine, complicated patients, complicated scenarios, and medication-assisted treatment, and that came up. And there was there certainly was perspective of, well, it's not safe. It's going to be safer than potentially the illicit drugs and heroin with fentanyl. So potentially a harm reductionist approach. I've heard individuals that say, well, they do that to extend their buprenorphine because they can't afford it. or they can't, they don't have access, and so they have to kind of make it last, and we'll start to inject a little bit. Some of that, I think, you got to tease out from, is this really the injection and struggling with craving the injection, the immediacy of effect, versus are they really trying to stretch it? I don't know. Gloria, what are your thoughts?
I haven't seen too many people who claim to be injecting buprenorphine naloxone, and I think they're usually very difficult, though, and once that horse is out of the barn, they seem to continue to want to really like to inject. It's like they need that level of stimulation in some way. So I think they're just very difficult, and even if you put them in a halfway house, what happens after the halfway house?
Yeah.
You switch them to Vivitrol during the halfway house setting. Do you do something like that? I also think most people at this level of use would not even wouldn't like to agree to switch to naltrexone. Because they wouldn't see any benefit in it.
Yeah, those are good points. I think very complicated. In retrospect, the ones that I've resumed on sublingual buccal buprenorphine that I've injected, I'm identifying complications, a couple of deaths, but I know that there's others that are not being identified with having complications. So it's interesting. The likability, I know that there's likability studies, different opioids. Buprenorphine is certainly liked less than other illicit opioids. So it's the parts of the state where this is going on. It seems to be just it's less. There's heroin all over, but there's I think less heroin than urban centers and other parts.
What about the legal ramifications of that? If you know that a patient is injecting or using the prescription you're giving them in a way that it's not meant to be used, and you document that it's a harm reductionist approach, are you at risk?
That's a great question. Does anybody have any insights on the call? JJ, you've got your hand up. Is that from before or?
I do think that the way you've said you documented is exactly what protects you, and I think it's naive to think that just writing something down alone is protection in court. But on the other hand, if you really are stating that it's a harm reduction intervention where you think that having a partial agonist with a ceiling on it is really intrinsically protective at the same time that you acknowledge that the person might misuse it, as long as you write that down, in the face of this being a life-threatening addictive condition, I think you're protected. As long as you're being honest, not only with your patient but with yourself, that you do believe it is harm reduction, as opposed to just writing it down automatically so you think it'll fly in court. If it really is genuine and it fits the case, I think you're absolutely protected. I think the landscape is set up that you're okay with that. And that's what I do. I'm very transparent, and I spend extra time in the record to make sure that I share my thinking, and I think you're all right.
Good comments. Thank you. Any other last comments? So this gentleman was offered the naltrexone induction protocol. Like I mentioned, he has an opportunity. He's sent to detox. He has a longer opportunity to taper because he's homeless and would be going inpatient. So and to a halfway house eventually, although that hadn't been planned out from the start. That was all kind of an ambiguous plan to see how he did first with the taper. And there's some insurance issues, if I recall. The taper was a 2 milligram buprenorphine, then 6, so 8 milligrams day 1, then 6 milligrams for 2 days, and 4 milligrams for 2 days, and 2 milligrams for 2 days, and then off. And clonidine, diazepam, and hydroxyzine are used symptomatically for withdrawal management. After 7 days, he left the detox and just decided AMA and had disappeared. So he was not interested in getting onto naltrexone. And that is the end of the third case. We're at 2:16. Trying to keep this within an hour, so we're going to stop here. Thank you all for joining. I want to remind everyone, if you have cases for the third Friday conference, it'd be great to get some other cases. Please just send me an email or give me a call if there's any interest, and we will be back for the third Friday in April. Thank you.
Great. I tweeted out some articles to ACMT and UTIM on the buprenorphine and cravings, as well as the use of buprenorphine after naloxone. So if you guys check that out, they're on Twitter.
Great. Thanks, Henry.
Yep.